Welcome back. This is part two of the Identifying Mental Health Crises in Library presentation. So we continue our discussion of de-escalation by homing in on techniques that are specific to common mental disorders that patrons, as well as colleagues, might present in the workplace. Now, the caveat here is that not every disorder looks alike. So what I'm doing is painting broad strokes with the intention of helping you to become more familiar with their signs and symptoms. In addition to educating you a bit about each one, I want to provide some specific de-escalation techniques that apply to them as well. So here are the disorders that I will be discussing. I made that decision based on the ones you're most likely to see in a library setting. So let's start with a mental disorder that is often hidden from us, but is perhaps most common among our patrons and colleagues. This used to be classified as mood disorders, but in the latest edition of the DSM-5, it was divided out into two sections: depressive disorders and bipolar disorders. And I want to focus primarily on the latter, as it's the most challenging of the two. Here are some statistics about the prevalence of these disorders in the United States. So it's important to recognize that while bipolar disorder has a lower prevalence, it often presents in a more serious way than depression. I think it's also interesting to note from these very recent stats that depression is increasing among two populations: young people, people between the ages of 14 and 25, and also older people. That's always been the case, but I think if you look at the post-pandemic situation, you can see incidences of all mental illnesses, but certainly depression higher. And the fact that only 35% of those suffering from clinical depression seek mental health treatment deserves our attention. Now, this could be because depression can be low grade and chronic, which in some cases might be perceived as not serious enough to warrant treatment. But we know there is a connection between depression and bipolar disorder and suicide, which means that we need to take the condition seriously in the best interest of the affected person to do so. This slide is a snapshot of the most common symptoms of both what we're going to call a manic episode and a depressive episode. Manic episodes are the highs associated with bipolar disorder, and depressive episodes would be called the lows. So individuals who are experiencing bipolar disorder are going to vacillate drastically between the right column and the left column. So usually intense emotion, changes in sleep patterns and activity levels, and sometimes unusual behaviors. So keep in mind these behaviors differ among people, but it is important to recognize that what you're seeing here is out of the ordinary, which again speaks to the importance of getting to know your patrons, especially those who are frequent attendees at the library. Bipolar disorder can be present even when mood swings are less extreme. So there's a term for that: hypomania. It's a less severe form of mania. During a hypomanic episode, a person might feel very good, be very productive and function quite well. You may not sense that anything is wrong, but family and friends who know them will recognize this as an erratic mood swing or change in activity level. And again, that could be evidence of uh, bipolar disorder. I want to say a word about severe episodes of mania or depression because they could have psychotic symptoms such as hallucinations or delusions. The psychotic symptoms tend to match this person's extreme mood. So, someone having psychotic symptoms during a manic episode, for example, may believe she is famous, has a lot of money, has special powers. Someone having psychotic symptoms during a depressive episode might believe he is ruined and penniless or that he's committed a crime. Certainly, psychotic manifestations of depression and bipolar disorder are rare, but they should be on your radar as as possible indicators that someone is experiencing either mania or severe depression. So, how might you engage someone presenting with depression? Well, it's likely that the consensus will be nothing unusual, right? Someone with low energy or fatigue is someone you would just want to respect. But it's always important to assess for suicidal ideation. It is a myth to think that you're planting the idea of suicide in their mind if you ask about it. Asking, are you having thoughts of suicide? Or do you have a plan for doing so? Is the way to go. Most people who commit suicide want to talk about it. So let's think about how you might best encounter a patron who is experiencing mania. Well, this person is more likely to appear annoying or distracted than harmful to themselves or others. So you really want to, of course, listen for quick speech, racing thoughts, uh, and recognize that it moves beyond just being annoying or distracting. So avoid patronizing or combative words. Telling someone during a manic episode to calm down will not produce the best results. Don't take anger or irritation personally. As I said, a person in a manic episode may come across as irritable, angry, annoying. Recognizing that it's not about you, but is part of their condition is important. Give the person space. Sometimes it's appropriate not to respond to certain behaviors or words. Sometimes you'll want to help the person focus. Um, so giving that person space to let it play out, as long as you can assess they're not harming themselves or others, might be the best course of action. Sometimes you have to let the depressive episode or the manic episode run its course. But always, I would suggest keeping a watch out on the person. You should be aware of the possibility that that person might put him or herself in dangerous situations or engage with other patrons in inappropriate ways. So keeping that person on your radar is imperative. We turn next to anxiety disorders. Again, more common than many mental disorders, um, and possibly more disruptive depending on the situation. Let's define our terms first of all. And the DSM tells us we first should distinguish between fear and anxiety. Fear is an emotional response to a threat that is real or perceived to be real. So someone walks into the library with a gun, you will have fear. It is and it is a natural emotional response. And what happens is you go into fight or flight mode. Now, anxiety is something a little different. Anxiety is anticipation of a future threat. And what makes it anxiety as opposed to fear is that it's often unrealistic or it's excessive or out of proportion to reality. So, someone walking into a library freaking out because she thinks she's being followed by someone with a gun when it's clear that she's not would be more anxiety and anticipation of a future threat. Often with anxiety, you have fear or it looks like fear, but the source of what is producing that emotion is different. The two overlap, but the former, fear, is more physiological based, which is sort of necessary for survival. And the latter, anxiety, is more psychological based, which is not to say it's in one's head necessarily and not realistic. It's just that it is an anticipation of a future threat, which is often hard to prove or see, and unfortunately, harder to believe when a person is in that state. Specific phobia, I want to define, is a marked fear or anxiety, it could be either, about a specific object or a situation. Flying, fear of heights, receiving an injection, seeing blood, the Dewey Decimal System. That was a little joke. The key here is that the fear or anxiety is out of proportion to the actual danger posed by the object. So if I see a spider on a table, I might get out of my chair or try and kill it, but I won't faint or have unrealistic thoughts that it will kill me. Someone with a specific phobia might have those thoughts and exhibit those behaviors. Now, a panic attack is a feature that's prominently seen in anxiety disorders. It actually can be used with or seen with many other mental disorders, but they don't have to occur in order for there to be anxiety involved. I will talk a little bit more about panic attack in the next slide. But defined here, it's an abrupt surge of intense fear or discomfort that reaches a peak within minutes, accompanied by physical and our cognitive symptoms. I think it's important to know a little bit about panic attacks because this is what we might see in libraries with our patrons. If you would like an inside view of a panic attack, I would encourage you to click on this YouTube clip. You will see this the many voices that seem to be going around in one's head during an apparent panic attack. It's not an exaggeration to hear someone say, I can't breathe, or I think I'm going to die. Those are very real feelings, experiences in the moment of someone who's experiencing panic. And here is a description of panic attack from the DSM. Palpitations, pounding heart, sweating, trembling, shortness of breath, feelings of choking or chest pain, nausea, feeling dizzy, chills, heat sensations, numbness, tingling. So as you look at these symptoms, what other condition are you reminded of? If you answered a heart attack, you're right. And you're certainly not a doctor. You're not expected to treat anyone with physical symptoms of this kind. But it is a good idea to know that panic attacks and heart attacks sometimes look the same from the perspective of an outside viewer. So, how do you know which is which? How do you discern what's a heart attack and what's a panic attack? And the simple answer, and the easy one, is to ask the person. You can't always know from asking, but usually the person's going to tell you what's going on, and they will confirm for you which it is. It's your best course of action there. So, how do you help someone who has a panic attack? Here's some suggestions from HealthLink BC. And I think the key here is to assess the situation, remain calm, help the person keep calm, engage the person in conversation. You can actually talk to someone and you can talk someone through a panic attack if that's what's going on. But you'll want to make sure you speak to that person in short, simple sentences. Never be unpredictable in your behavior, in your approach, avoid surprises. And if you get to the point where you are talking calmly about the situation, you can help the person breathe, you can help the person count slowly to 10 or backwards from 10. These are all techniques with the intent of helping to bring someone down, to calm someone down who might be experiencing a panic. So our next disorder is schizophrenia. There are other psychotic related disorders that I'm not going to talk about, but this is one of the most misunderstood, and I think feared disorders because it has a specific manifestation that a lot of us don't understand and might be threatened by on some level. So let's start with some general misconceptions about schizophrenia. Common misperception, often perpetuated in the media, is that people who live with schizophrenia have split personalities. Well, this is actually a different disorder, and it's called dissociative identity disorder. So persons with DID, dissociative identity disorder, have two or more distinct personalities, and they can alternatively switch from one to the other. This is not someone with schizophrenia, however, although it may appear that way. Split or dual personalities is not a symptom of schizophrenia. People living with schizophrenia can lead functional lives. They may struggle, and they may struggle throughout their entire life, but there is treatment, and treatment is effective, and they can actually recover from the situation as best as possible and pursue meaningful life goals. One of the big misconceptions of schizophrenia is that those affected are violent. And research has shown that people with schizophrenia are much more likely to be harmed than to harm others. It does depend on whether that person is being treated, since it's also known that the illness can get worse over time. And finally, one of the misconceptions is that schizophrenia and drug alcohol abuse are separate, but it is common for people who have schizophrenia to have problems with drugs and alcohol because they're using them as a coping mechanism, maybe to quiet the voices, to be able to be more social, all those things that drugs and alcohol can give us. But we do know that drug abuse and alcohol abuse can increase the risk of suicide, trauma, and homelessness in people with schizophrenia, as well as increase the risk of developing other mental illnesses. And now some common symptoms of schizophrenia. There's a lot here. I'll try to summarize as best as I can. I want to distinguish between positive and negative symptoms. Positive it does not mean positive in the sense of benefit. It means that it's a symptoms that it is an additional behavior not generally seen in people who don't have schizophrenia. For some people, these symptoms come and go. For others, they become stable over time, and they can be severe and at other times not noticeable at all. So we're talking about hallucinations, when a person sees, hears, smells, tastes, or feels things that are not real. Often hearing voices is the case. We're talking about delusions. So this is not so much seeing or hearing something that isn't there, but believing things that are not true. So believing that people on the radio or the television are talking directly to the person. Sometimes people who have delusions may believe that they're in danger or that others are trying to hurt them. Thought disorders is simply odd or illogical thinking, trouble organizing one's thoughts. Sometimes a person will stop talking in the middle of a sentence, or you'll hear words that have no meaning, that are jumbled. Sometimes you'll see movement disorders, and this is when a person exhibits abnormal body movements. Person may stop talking or moving entirely. That's a rare condition called catatonia. Now, moving on to negative symptoms. This is a category that refers to what you don't see or a lack of something. So talking in a dull voice or showing no facial expressions, having trouble communicating, talking very little. The symptoms are harder to recognize as part of schizophrenia, and they can often be mistaken for other conditions like depression, for example. Cognitive symptoms are not easy to see, of course, but they can make it hard for people to communicate, as well as to have a job or take care of themselves. The level of cognitive function is one of the best predictors of a person's ability to improve and cope with this mental disorder. Often those symptoms are detected only when specific tests are performed. So now that we have a handle on the symptoms of schizophrenia, let's talk about how you might handle someone who is experiencing a schizophrenic crisis. It's important to note here that you can't reason with acute psychosis. So arguing with the patron that the hallucinations and delusions are not real is not recommended, not the best course of action. You can be honest, however, and say something to the effect of, I don't see what you're seeing, but validating the whatever emotion this person is presenting. Often it will be fear. It will be not understanding, what's going on. It could also be embarrassment, shame at the fact that this is happening in public. Sometimes there is not that kind of self-awareness. As with all mental disorders, keeping a calm demeanor is key. Beyond that, avoiding direct, continuous eye contact or touch. So this is important. We don't want to make any surprise moves toward a person who is seeing hallucinations or having delusions, because we could contribute to the anxiety that these are producing. So avoid touching. If it's appropriate to help the person move to a different area or sit down, that can often serve as a calming mechanism. This is also a reminder that keeping people on call is important as a backup, but not calling on too many people for backup, because that again might further agitate the patron. Next, we move on to PTSD, which stands for post-traumatic stress disorder. When you think of someone with PTSD, you're probably picturing someone who has a military uniform. And while it is the case that many veterans, many of our soldiers who have fought in wars, come back with post-traumatic stress disorder, the truth is that anyone who experiences exposure to a traumatic or stressful event, either experiencing it or witnessing it, is prone to PTSD. You can probably imagine the connection between PTSD and anxiety. Many of the same symptoms are going to present. But there are some symptoms specific to PTSD that I want to note. Symptoms, by the way, like those on the screen, can begin immediately or soon after the traumatic event. They can also happen years after. So just because someone is showing these symptoms doesn't mean they're responding to something that's just happened. And as you might imagine, these symptoms can cause significant problems in work or interpersonal relationships. They can even be severe enough to prevent a person from completing daily tasks. So let's talk about each one briefly. Intrusive memories. So these are recurrent, unwanted, and distressing memories of the traumatic event. Flashbacks are the experience of reliving the traumatic event, just as if it were happening again. There might be dreams, nightmares, but anything that could remind that person of the traumatic event might cause severe emotional distress or a physical reaction. Now, naturally, and sort of the opposite might occur in that the person might avoid or try to avoid thinking or talking or being reminded about that traumatic event. What is often seen, however, whether that person engages in intrusion or avoidance, is that there are negative changes in thinking and mood. So, negative thoughts about oneself, hopelessness about the future. Sometimes it comes across in memory problems. And of course, all of that affects one's ability to manage relationships, with family, with friends, with librarians. Sometimes the negative changes can involve a lack of interest in activities, feeling emotionally numb. Note that the symptoms in this case tend to look an awful lot like depression. Finally, we can recognize in individuals with PTSD, there are changes in physical and emotional reactions. So this person will be easily startled, always appear to be on guard for danger. And sometimes you'll see people manifesting PTSD with self-destructive behavior, drinking too much, sleeping too much, irritability, anger, aggressive behavior. So you can see how startling someone with this disorder might fuel the problem as opposed to fixing it. If you'd like a visual of the previous slide, I invite you to click on this YouTube clip. Note the variety of faces of PTSD survivors. Note also the sources of PTSD. I hope you recognize that we may interact with these individuals in the library all the time and never realize it. So what's the best way to help someone who's experiencing an actual flashback? So your job here might be to bring the person back in touch with reality. Have him describe what he sees. Try to engage. And if it's appropriate, to tell that person that even though the event feels real, it isn't. In other words, reminding that person you're having a flashback. Helping that person get in touch with their immediate surroundings is a good idea if possible. Sometimes it's not. Sometimes someone is so involved in a flashback that it becomes or appears to be a panic. Encouraging them to take deep, slow breaths. And as I've mentioned before, avoiding sudden movements or surprises, anything that might startle that person. So being gentle in your voice and body movements can make a difference here in bringing someone back from a flashback. So our final mental disorder I want to cover is the issue of substance use. So substance use is one of the most prevalent in our libraries, though it may not always be the most obvious. To get the scope of the problem, I want to cite an article from the Journal of Community Health published in 2022. The authors in this study conducted a cross-sectional survey in 5 randomly selected states, and they asked library staff about substance abuse and overdose in their facilities, and also how prepared they thought the library was to respond. You can see here, substance use in the library is present. I probably don't have to tell you that. But you can also see from that last statistic that staff and administration are interested in addressing the problem. Over 90% of respondents in this survey wanted to receive additional training on this topic in particular. The information on the next few slides are taken from a PowerPoint presentation presented by Steve Albrecht for the American Library Association in 2018. So just a couple of terms to define. Taking a substance is not the same thing as abusing a substance. And we're often going to witness not so much active substance use, but withdrawal from the substance. So when a person builds a high tolerance for the substance and they no longer can get their hands on it, or they want to try and gain sobriety, they can be in withdrawal. And that can create tremendous irritability, discomfort, and sometimes violence. I want to focus on 2 different substances in this training, although many more will show up at our library doors. alcohol and opiates. These appear to be the ones most commonly used. And these next slides will give you some basic information about each. Alcohol is actually a depressant, though initially it might appear to have the opposite effect, and it can slow down reaction times and affect motor skills. Note its connection to depression if it's chronically used. Notice also that there is the possibility of seizures if the person is going through withdrawal. Many of our patrons who are intoxicated with alcohol are likely to go on under the radar, but if not, they need to be on our radar because of the possibility of alcohol poisoning and overdose. I think sometimes people think that, oh, it's just alcohol, but there is something real about ingesting too much of that substance. And so here are some signs to look for. As you'll notice, a lot of those symptoms are similar to other disorders that we've talked about. If you suspect someone is in this condition, as indicated by these signs, definitely the go-to is to call 911. And now let's turn to opiates. Heroin, pain pills, methadone. Opiates are a type of drug used to reduce pain, and they work by binding to specific brain receptors to minimize the body's perception of pain. So just like alcohol, a person can develop a tolerance to an opioid, which means that they need to use it more and use more and more of it to feel normal or to achieve the feeling they had the first time they took the drug. And this physical dependence can lead to symptoms of withdrawal, as I mentioned, when the medication is stopped. So opiates have the potential to be more serious than alcohol. They are also a depressant, and they have a distinct presentation there, as you can see. Muscle relaxation, being on the nod, which looks like they're about to fall asleep, and slow pulse, slow reactions. Let me take a quick diversion here and talk about opioid use in Michigan. The date of these stats is 2020, but they're reporting 2018, which is often the case when you read articles. They report data 2 or 3 years earlier. And these are pre-pandemic stats. So we know that since the pandemic, there's actually been an increase in opioid use and overdoses. Opioids are not as easy to acquire from a doctor these days, but what that means is that users will try to find it elsewhere. And that elsewhere could be more dangerous drugs like fentanyl, heroin. Often they will not know what they get off the streets. They won't know what's in the drug, and so there's greater risk. When a person takes too much of an opioid, they can reach the point of either being really high or potentially overdosing from that ingestion. So here's a comparison of those two conditions: slurred speech, sleepy looking, nodding, very relaxed muscle movement, slow reactions. That's someone who is not to the point of overdose. And of course, when you get to the point where someone is perhaps overdosing, you're looking at slow heartbeat, deep snoring, gurgling. It may appear the person is not breathing, or maybe it's extreme sleepiness, difficulty to awaken, or a heavy nod, no response at all to stimulation. So when the person is experiencing a potential overdose, of course, the course of action is to call 911. And what to do if someone is just really high is a bit of a judgment call, but certainly you would want to monitor the situation. And of course, because we're talking about one of the most serious conditions that you might be presented with, you can rely on what many libraries are offering in either vending machines or behind reference desks, and that is Narcan, or naloxone, it's called. So I would encourage you, if you have not done so, to get some training on how to administer Narcan. These two links will help you. Naloxone is an opioid antagonist, which means it reverses the effects of opioids on the body. But it is important to note that this is a temporary solution, and it does not stop the overdose for good. It's just really designed to help you buy time until a medical professional arrives on the scene. Note also that someone who is given Narcan might wake up immediately, but that doesn't mean they're in the clear. They still need medical attention. And if they wake up after being in a near overdose situation, they may be startled, which means they may be agitated. So make sure you have appropriate backup. The toolkit website linked here includes essentials for first responders, and it will show you the proper procedure for administering Narcan. Note, especially if you watch the video, the 3 Ps: peel, place, and press. So to wrap up our discussion today, I want to share a summary model that you can use for all patron interactions, whether they're mental health or non-mental health, crisis or not in nature. This is the model that I will apply to an approach to the case studies that follow in this toolkit. Here's an overview of the model: assess, engage, follow up. And I have conceptualized it to be general enough for you to tweak the model based on the situation that you're encountering. This model is compiled from my own thinking about the topic, but also the research about de-escalation and conflict management, as well as some of the specific disorders that I've talked about in this part of the training. So let's talk about each one in turn here. First of all, assess. So what is actually going on when you have a patron interaction? That's the first question here. What are you seeing? What are you observing? What are you hearing? What kind of mental state are you perceiving that person to be in? What kind of mental state are you in? So all of those are important first questions to ask. This is about self-reflection. And I hope that you're able to use some of the skills and knowledge that you gain from this training and others, because that's the more knowledge you can bring to a situation, the better, of course. I think it's also important to ask, is this a mental health crisis? Is it merely problematic patron behavior? And I would say, under the second bullet point there, what is my role? Who else can help? Remember that your role is a librarian. You are not a social worker. You are not a security guard. Well, unless you're listening to this and you're a security guard. You may or may not be an administrator. So this is important to recognize what um, you need to know what is within your scope of practice, but also the other roles that might be of assistance for you or could take over in any given case. I have a question here regarding space because I think it's important for reasons to keep everyone safe. You may have to move to another area of the library that's more open or away from other patrons. Safety is key, and it really is much better to err on the side of being too safe than to not be safe at all. Now, I present these questions to you to ask yourself, but I also recognize that all of this often happens in a split second. Mental health crises, concerns, problematic behaviors, they're often erratic. They seem to come out of nowhere. So the expectation that you're going to be able to do a thorough and even accurate assessment, we need to give ourselves a little grace when we think about this particular part of patron interaction. So if you do decide to engage, because one of the decisions you may make in the assessment phase is to not engage or to let someone else engage, the next question is how to do that, how to engage, and put in some thoughts and skills about how best to do so. So we covered earlier in this training how to respond to numerous situations in our discussion of de-escalation skills. So the general rule of responding with calm, welcoming, yet firm verbal and nonverbal communication, I should add, is important. But so is the question, how do I keep myself safe? Again, I've said it before, but safety should be first and foremost on the mind of any staff member encountering a patron. Safety for all, including you, maybe especially. So keeping that in mind as you make decisions about how to be calm and welcome. Maybe you don't touch the patron. Maybe you try and get on their level. Certainly being aware enough of your surroundings that you have an escape plan if you need it. And maybe most important, it's important to recognize when an encounter simply isn't worth the risk it might present. In that case, calling 911 or the police or getting others in the library involved is certainly warranted. Now, finally, we have the follow-up phase. And this involves asking a couple of questions. How do you know, or how can you be sure that the problem is resolved? Sometimes you can't. But understanding the protocols that your library has in place about incidents involving patron encounters, including any follow-up paperwork that needs to be completed, that's part of the process. But so too is the psychological piece. And this is one that often gets missed by administrators, by individuals who have difficult encounters with patrons, is that we need to have in place and also take advantage of support structures that will allow us to debrief the experience, that will allow us to take care of ourselves. Maybe it means taking a break. Maybe it means taking time off. Yes, but these kinds of experiences that are sometimes missed really can make the difference in creating a culture that is more trauma informed. So this brings us to the end of this part of the toolkit, and I invite you to move forward in the kit to consider some real life applications of the material in this curriculum. Members of the Michigan SAG committee have offered some real life case studies based on their lived experiences, and I wrote some narratives about each. I talk about how I would apply the assess, engage, follow up model, as well as the other content material in this training to the situations. I hope you find them useful. I hope you're able to have good conversations with colleagues and others about them. You'll find that I offer as many questions as I do answers, but that's purposeful. It's all in the interest of raising discussion around these very important issues. So I have my references for the presentation here. I encourage you to look up any that you found interesting. And finally, I am open to comments. I'm open to questions. I want to continue the dialogue with you if that is helpful. So I've been given permission to put my email address here. You're welcome to contact me about questions, concerns, anything to do with this material. So it's been my pleasure and privilege again to share a little bit of my research and the research that many others have done about how to effectively identify, understand, and respond to mental health crises. My wish is that it is helpful for you. Thank you for the good work that you do every day on behalf of your community.